Thank you. Two things I'm going to think about a little bit today. One is interdisciplinary education. And I think when we think about interdisciplinary education in a teaching and learning capacity, this is slightly different to the interdisciplinary working that we think of in a clinical environment. So I'll go and describe that. And I think we do a lot of this style of teaching in end-of-life care. And then I'll also go on and touch on the diversity that we may have in our learning groups and some of the things that we can use as facilitators to make the most of that diversity and share the expertise that we have in the room. We are there as facilitators, but there's lots of knowledge out there already. I think you are all here because you know how important end-of-life care training is and what a difference it makes. Many of you will have seen the NC Pod report that came out. This is a national review of end-of-life care in acute hospitals that was published in November 2004. And what came out very strongly in the recommendations was this recommendation of needing to train patient-facing healthcare staff in palliative and end-of-life care. And they talk about providing training in undergraduate and postgraduate formal education, but also to have regular training for patient-facing healthcare staff. The note that they put on implementation is that we should be embedding palliative and end-of-life care training as a core competency for all clinical staff in the same manner that we would do basic life support. So that is a huge task. Across the NHS workforce, we've got 190,000 doctors, over 400,000 nurses. You know, we've got nearly 1 million clinical staff out there that are going to need regular end-of-life education, which is a real exciting opportunity for us as we move forward. But I guess logistical challenges of how we're going to operationalise that to be considered as we go forward. So we're going to think a little bit about what interdisciplinary education is, and then I hope that you go away being able to recognise how you are already meeting the diverse needs of the learners within your groups, or thinking about what you might do differently when you go back out into practice. What tips might you take away and just tweak what you're doing to try and meet those diverse needs? So I guess in healthcare, when we think about interdisciplinary, we're often thinking about different specialties working together, and we see that working really effectively in clinical MDTs, where we bring radiologists and surgeons and oncologists and ourselves together to make decisions about patients. When we're talking about interdisciplinary education, it's a method for teaching and learning that combines multiple subjects to create new lines of thinking and to address complex problems. So rather than just focusing on a very specific clinical issue, we might bring in something like language and literature to help enrich that learning, or we might bring in a topic around medical legal care or ethical thinking. And that allows us to think about the subject matter at hand in a really rounded, holistic manner and brings lots of learning opportunities with it. That helps us to accomplish two things that traditional methods of education doesn't. It expands that learning experience by drawing on multiple subjects at the same time, and it promotes critical thinking in our students. And that's really important because we want them to go away from the training that we deliver knowing some facts. We may want our new district nurses to go away knowing that if a patient is dying and they are distressed, giving a small amount of midazolam might help, and how they do that injection. But we also want them to be able to think critically about why they might need to be doing that. Have they done that assessment? Have they had the conversation with the patient and the family about the indication of the drug and the consequences of using that medicines? So we're trying to make rounded clinicians by teaching them in a more rounded manner. And the more I read about interdisciplinary education, the more I think we do this all the time. It's very rare that we don't think about clinical issues alongside the legal or ethical or communication challenges that we face every day. And it's why there's lots of us in end-of-life education circles that are communication facilitators alongside clinicians, and we can bring all those different skills together. So as I go through this talk today, I'm going to link some of this theory in with some of my teaching experience and use that as a bit of a case and a crutch to demonstrate how we put this theory into practice. So one of the courses I deliver in hospital is a workshop on clinical uncertainty. That came about from clinical need. We knew there were lots of patients in the hospital who were sick enough to die, but may also benefit from active treatments, and clinicians were finding it hard to understand or to make decisions about how actively we treated people. So we did some work with colleagues and we developed a workshop that looked at the clinical elements of treatment escalation plans, of decisions around resuscitation, of anticipatory clinical management planning. But we recognised actually to be able to do those things clinically, you needed to have some legal knowledge. You needed to understand how the Mental Capacity Act worked. You may need to have some ethical reasoning. You might be facing some quite difficult ethical challenges around level of treatment escalation. And certainly when I spoke to colleagues in the acute trusts and out in community services, they're saying, actually, we might know how to make the decision, but we find it really difficult to communicate that sensitively at this time of high emotion. And therefore, we've got this interdisciplinary approach to education in that we are bringing that clinical teaching alongside our communication skills challenges. So we might bring all of those elements into that workshop we deliver. We can also bring language and literature into the classroom as well. Some of you may well recognise this gentleman. If you've got small children, you're probably able to recite "I'm going on a bear hunt," which is one of Michael Rosen's most famous books. But he also wrote his diary about being ill with COVID. And this is one of the quotes from that. And I think this is a really powerful piece of literature to bring into clinical teaching. Because what this does is it brings a real person into the classroom and it brings their experience. It brings the clinical decision making into context. We are making some very difficult decisions at times about whether we actively treat people. And it also brings in that patient-centered, what do I want bit in. And it reminds us how important it is to be constantly going back to our patients and saying, what do you want? What's important to you? And I think by bringing this element of literature and storytelling into our clinical teaching, it starts to enrich the message that we are giving. So if you read the theory about interdisciplinary education, which I think a lot of you are doing every day, day to day, it talks about these benefits of expanding the learning experience, of enriching that knowledge, of making that theory clinically relevant, and it enables staff to think critically so that they can make decisions and support patients in the way that we want them to. But it can also be quite challenging, because if we are developing education packages that use lots of different disciplines to teach, we need to think about how we develop that and deliver that. Do we, as the teachers, as the facilitators, have the right level of skill to be able to teach across that array of topics? And what can we do if we don't? So as I was developing that workshop to think about clinical uncertainty and treatment escalation plans, I was very mindful that I had expertise in developing future care plans and anticipatory clinical management plans, but I had less expertise in treatment escalation plans. So what I did was I went to my acute colleagues and we put together the package of training together. I was also mindful that although I do some communication skills delivery, I'm not the expert on this. And I went to my colleagues who are, to make sure we incorporated the right tools and techniques within that teaching that I could then deliver. And actually from developing it together, we then decided this is teaching that isn't just about end-of-life care. This is about general good care in hospital, and this needs to be delivered by palliative care alongside acute clinicians. So it's grown into something because we took that interdisciplinary approach to planning and now delivery. It gives us the challenge of thinking, well, what is the right level of complexity? And we understand that level of complexity by knowing our learners, by knowing what jobs they do, what roles they have, what experience they might do. So we have to be talking to them about their experience, and some of that we will do prior to preparing our teaching, and some of that we can do within the classroom, and I'll talk a little bit about that as we go forward. When we are dealing with big complex topics, it can be difficult for us to remain objective, and we have to take that step back as a facilitator and be able to look at the different viewpoints and bring together different skills from the room. And sometimes it's hard, but sometimes it's really easy to give lots of guidance, and that's not always the right thing. Sometimes it's about enabling people to make the right decisions and take their skills forward. And we will adjust that in our classroom as we go day to day. Any key questions so far?
No, nothing in the chat as yet.
Right. So I think we are delivering complex interdisciplinary training a lot of the time when we are teaching around end-of-life care. And we are often teaching to diverse groups. That might be a group of learners that have got diverse learning needs. So we may have people in the classroom that are very, very experienced and people that are very new to practice. It's not uncommon to have students alongside quite senior clinicians. So we want to be able to adapt what we do based on the learning needs of those individuals and think about the prior learning. And we also want to think about the theory of learning styles and learning preferences, because that helps us meet the different learning styles that people have. The other diversity that we might see in our classrooms is with the workforce that we are teaching. We may be teaching people from different professions. That automatically brings different experiences, different roles, different expectations, lots of shared knowledge to bring. We might bring people from different specialties who might need a different level of knowledge or bring a different approach to care. And we are certainly working within a healthcare system where we have people from a huge number of cultures. And I'll talk a little bit about cultures as we go forward. So how do we then start to explore the diverse learning needs of our learners? There's a little bit of a Boy Scout in me when I'm thinking about teaching. The best teaching has always been thought out and well prepared. We need to think about what our learning outcomes are, and we need to know our group to a degree so that we have a starting baseline. When we go into the classroom, we know what we want to deliver. But once we get into the classroom, it's useful to know who we've got in that room. I'm talking about classrooms. This might be a bedside teaching session. This might be a conversation on the phone with a district nurse, lots of teaching environments. So when I talk about classroom, I mean any of those kind of teaching environments. But if we're doing formal teaching, I find it really helpful to do some introductions and to do some agenda setting. If it's a small half-hour session that I've got, or 20-minute session or something, I might just skim the list of attendees to get a feel of who's in the classroom. But for a workshop like the one I do on clinical uncertainty, I actually spend quite a long time going around that room, asking people who they are, what role they have, what expertise they have, and why they've come, because I want them to set the agenda. That can take quite a long time, but what it does is it helps me understand the expertise I've got in the room that I can use. It helps me set the bar of where we need to start. Where's their baseline? How much do I need to build on what they already know? And it shares their learning needs and expectations. So if I do an exercise like that and I'm teaching something like DNA CPR decisions, my overarching learning objective might be to have clinicians that are able to make timely decisions about CPR and communicate that effectively. But when I ask my learners what they want, I might get a huge spectrum of things. They might want to know about decision making, they might want to understand about the law, they might want to think about conversations. I can also see from that agenda setting that I've got a spectrum of expertise in the room. I've got specialties ranging from surgery to frailty to medicine to critical care. I've also got F1s ranging up to consultants. I've also got an international medical graduate in the room. That's really important because they may have trained in a healthcare system where palliative and end-of-life care isn't recognised as a specialty. They may have worked in a healthcare system where DNA CPR decisions are not made, they're not part of healthcare. So suddenly arriving and working in the UK, it will be a change to practice, but it will also challenge their thinking and will potentially challenge their thoughts and their values and their beliefs about healthcare. So they may have some really interesting insights to share, but they may also have some different questions. But from that agenda setting, I can see that I've got people with clinical need. I've got people who want to know when to make that decision. They want to know something about disease progression, around disease trajectories, and we can focus on some of that clinical element. There are definitely questions around the law, around the moral dilemmas of where we go here, who can make decisions, is a legal element, but actually how we handle that has real communication and ethical tendencies. So that agenda setting is a really powerful tool to allow me to assess that diversity of expertise, roles, responsibility and knowledge within that group so that I've got that in my mind when I'm moving forward facilitating that session. The other thing I think about when I'm preparing is that diversity of learning styles. And many of you will have come across this VARC model. If you've not, I would say go away and Google VARC learning preferences and work your way through the questionnaire. Each time I do it, I come up with a slightly different weighting, but it gives you a weighting of whether you are somebody who prefers or takes in knowledge better with a visual stimulus, oral, read, write, or kinesthetic. And when we teach, we will have learners with each of those learning preferences. In reality, lots of us are fairly multimodal and will be able to learn in different ways, but we might have a strong preference. But actually, if we're preparing a workshop or a training session, we want to try and meet all those different preferences. So I may be teaching you to suck eggs here, or you may be new to this. I'm sorry if I'm repeating, but I think it's useful to kind of think again, well, actually, how might people with a visual preference learn? They will like seeing things visually in different formats. They will like space, they will like graphs, maps, plans. So I might use a graphic that I might go back to through teaching. So in my clinical uncertainty teaching, I'm trying to get clinicians to think, have they got a patient sat in front of them who is going to get better, who is definitely going to die, or are they somewhere in the middle? And if they're somewhere in the middle, how are we going to make that decision around care? So having that graphic that we come back to time and time again is a useful base for a visual learner. I might also use images that portray a message. So when we're thinking about future care planning, the key element of that is that we are trying to understand what somebody wants and then pass that message on, make sure that other team members understand that. So I might talk about passing the baton of care and use that image as I go forward. For those with an oral preference for learning, these are people who like learning through discussion, through stories, through guest speakers, through chatting and having conversations. And you will know your colleagues who learn in this manner. So I want to bring into the classroom an element of conversation and discussion so that we can take that forward. Those with a read-write preference for learning like to see things written down. They might like lists, they might like notes, and they will benefit from having hands-out references and resources that you might give out at the end of the session, or you might have as hard documents within the session itself. And then we will have those individuals with a kinesthetic preference. These are people who learn best when they are using their senses, when they are moving their bodies, when they are doing practical experiences, and they gain a lot from examples from cases and from trial and error. So when I apply that to teaching and developing a session, I want to think about how am I using the images and the visual things that I've got? Have I got the right resources for those read-write learners? Some of that might be on slides, some of that might be on handouts, some of that might be on website links that I send away. Have we got an element of discussion and of activity? So it might just be about having a conversation. It might be about doing some low fidelity simulation work. So if we're thinking about ACMPs, let's have the story. We might do some role play about conversations, and then we might actually write out the ACMP and put it down on paper. That activity, that taking it forward, makes it a little bit more real and embeds it. And you'll notice actually that both of those, all in those kinesthetic learners, stories and cases are really key learning opportunities for us to take. So when we're thinking about meeting those diverse needs of learners, I often think about how we use storytelling as a tool. Storytelling is really powerful because when we tell somebody a fact, we just trigger small parts of the brain. But when we tell them a story, we start to activate the sensory cortex. That enables an individual to create characters and to evoke emotions. So if we start to use Michael Rosen's story or a case to think about clinical uncertainty, people will start to have that emotional response and they are more likely to engage and to remember some of that learning that embeds within. And if we can use stories, we can promote some of those healthy behaviours in learners. We can try and promote professional identity and group cohesion. And when we've got a diverse group of professionals sat in a classroom, they may start the session saying, I'm not going to have the future care planning conversation because that should have been done in oncology, or isn't that the job of palliative care, or isn't that the surgeon's role because they know whether or not they will operate on this person. By the end of the session, we have got a group of professionals working in different fields saying, this is important and we all have a role to play. And I might do this bit, pass it on. But we will try and develop that group identity so that everybody's in it, and we foster that sense of end of life care is everybody's responsibility. And we are seeing storytelling evolving. It's been around for thousands of years. You know, if you go back to caveman days, there's pictures of storytelling that helped generations tell stories and pass learning on from generation to generation. We are now using storytelling in teaching, but we use those stories in images, in cartoons, in pictures, in words, and we're seeing the use of social media and memes and all sorts of things that we can use to boost that, and we will continue to do that. So those stories are really important, but we need to make sure that the stories that we use illustrate the learning point and they generate the right discussions to get the learning points across. And we need to make them relevant to the learners. So if I am talking about decisions around resuscitation to a group of GPs, I want to think of a challenging case in a community setting. If I'm doing it in the hospital, I might want to think about a challenging case in a hospital setting. I want to make it relevant to them. And I have some cases that are very generic that, depending upon who I'm talking to, I can change the angle so that I can use it in different manners. I also want to use the stories that the group members bring because they will share their experiences, and that's also really valuable cross-pollination of learning. I suppose one of the other things, we've talked about diversity of learning styles and of professions, but actually diversity of culture is huge in the NHS, and there's lots of different definitions of culture. But I quite like this one. It's about a way of life, especially the general customs and beliefs of a particular group of people at a particular time. And you will hear about culture within organisations. Within one hospital, they may have a culture of open, transparent, no blame investigation. Other places may have a culture of actually being much more insular and quite defensive about practice. We also know when we meet with different specialties, their views, their beliefs, their customs are different because of the nature of the work that they do. The culture of people that work in very acute environments, they're often very aware of end-of-life care because they can see pragmatically how life can change on a kind of really small change. we often point fingers at surgeons and say they're not engaged in end-of-life care, but actually they're really good at making decisions around who they operate on and not, because they've got very clear-cut interventions and quite clear figures around potential outcomes. So we've got different cultures and different specialties. The other thing that's fascinating about doing education where you invite stories is that you start to develop those stories or hear those stories of cultural experience from people's own personal lives, particularly when we are working in a very varied workforce. And I think that gives the learners insight into the background and the learning and experience of colleagues. Bringing nurses and doctors together helps the nurses see why doctors make decisions and vice versa. Bringing our new international medical graduates or new cohort of nurses that have been working in India up until now into the same classroom as UK trained clinicians, we can start to shine a light on the difference in the training that they've had and the difference of the healthcare systems that they've had. And we move that conversation from why aren't they doing that to how do we help them to do that? How do we help them to work in the culture of the NHS, the culture of the UK? So I think it's a fascinating area of work. So I think the stories are really important. They help us put that theory into practice, and they help us bring together all the diverse elements of the groups that we've got in front of us. So I think that's me coming towards the end. I think interdisciplinary education, where we bring together lots of subjects within one training, actually has a vital role in education if we use it well and enables us to enrich the training that we give. I think as education facilitators, we need to be able to recognise the diversity in the learning needs, the prior knowledge, the skills of the group, but also use those tools that we've got in terms of stories and conversation facilitation to try and pull that together and enrich the learning as best we possibly can. So as we move to questions, I want you to think about what you will do differently to meet the diverse needs of your learners. I'm really interested to hear what you already do, what tips you've got to try and meet the diverse needs of people in your group. And then I'm going to go back to Michael Rosen to say, when we are delivering education, it's an adventure. And I just want us all to enjoy the adventure together so that we can continue to improve the life of those patients that we are involved in the care of.
You're welcome, and thank you for asking me to speak. Just to give you a bit of a warning, I'm in a shared office now. I've hopefully managed to get rid of all the consultant cardiologists who were in the office with me because they didn't really like the idea of listening to me speaking for half an hour, but they might come back in again. Just sorry if they do, but they have said they'll clear out for half an hour. So I suppose the reason I've sort of become aware of this is that as part of being the clinical subdean, we have regular clinical meetings in the University of Liverpool with the dean, and all hospitals who take medical students for Liverpool University have to have a clinical subdean for either the trust or a specialism. So I'm the clinical subdean for the hospices within Merseyside and Cheshire. And there's been lots of talk in the university, probably for the last 2 or 3 years, about how we might not be managing student learning as well as we could because of the change in the demographics of how people learn and their response to digital learning. So I was lucky enough to be at one of those meetings when we had a speaker who's called Mr. Redmond, who actually was the first person I'd heard really speaking about generations and how they learn. So it started me thinking about it, and then this session happened along coincidentally. So I suppose, just as following on from what Claire's said, we as educators and facilitators have got a responsibility to educate whoever we're with to the best of our ability, but sometimes we may feel that the teaching sessions don't go as well as we would like. We might get feedback that we weren't necessarily expecting. And for us, we then need to have a think about, is there anything we could do differently to actually manage that teaching and make it more beneficial for our students, but also as a consequence for us, because we all know that if we don't feel that we're facilitating or educating as well as we would hope, that has a negative impact on us into the future when we're actually teaching other people. So I suppose initially what we have to do is think about the generations and where we fit. So I'm presuming that there's nobody online who was born before 1942. I'm really sorry if there is. If there is, you're a traditionalist. But generally, those are the generations and what they're called. So you might sort of be on a cusp between one or two. I have to declare that I'm a sort of a cusp between baby boomer and Generation X. I would probably put myself more in the baby boomers than the Generation X. But obviously, whoever you are, you will know which generation you currently fit into. And those generations are used for sort of throughout the literature in educational. So partly my generation, if you look at the general characteristics regarding working and to some extent learning, we tend to feel the need to be present in work. We're generally the parents of millennials, but not always, just depending on when you might have had children. But we have been seen as over-parenting. So helicopter parents, so making sure everybody else's lives run very smoothly, and people becoming very dependent on us to make their lives run smoothly, if that sort of rings any bells with anybody. We had a life long before technology, which obviously the subsequent generations really can't fathom. We generally arrive early, leave late, don't necessarily take all of our leave, and we generally feel that that's how everybody else should work, and consequently can feel a bit uppity if people don't do that. So if we move on to the more important recent generations, because these are going to be the groups of people that generally we are teaching and facilitating. Generation X, if I've got two slides which show different sort of versions of how they operate. So for Generation X, which is 66 to 80, if you fit into that category, then generally you think the world revolves around you. Your view of authority is ignore it if possible. Your view of relationships is generally central and caring, so it's a really important thing to you. For the millennials, you pick and choose what life looks like, so it's very much on your terms. You're a sort of a user rather than anything else. If you look at who your sort of more authority figures are, so your line managers are, really try and choose them carefully if you possibly can. So sort of try before you take on permanent jobs. And then you've got round the clock relationships which never cease. So you can be constantly involved in relationship work. For our Generation X, which is our current undergraduate group effectively, then generally want to make a difference. They want to work alongside their line managers rather than be sort of somebody who answers to them. And they're very keen to be collaborative in their relationships. Oh, sorry. Their view of careers varies. So Generation X generally think that having a career is a bit of an irritant. That millennials and Generation Z have changed a bit. So they want their career to help solve issues. The view of technology is very different to baby boomers. So baby boomers see it as a sort of well, this is the world we've been catapulted into. Generation X have sort of had to learn on the job effectively with technology, and sometimes some people embrace it, some people see it as a necessary evil. Millennials employ it, and Generation Z just live it 24 hours a day, and that's often what we see playing out when we're teaching. Interestingly, views of future, baby boomers are in the I'm going to retire soon mode. Generation X generally see it as generally hopeless across the board. Millennials are optimistic, and Generation Z see it as something that they can work alongside to solve what the future is going to look like. So sort of the reason I've put that through is it sort of informs what our Generation Z students are going to be like. And obviously you can then adapt the other generations, because if you're teaching more senior healthcare professionals, then you are going to have to employ different options depending on which generations you feel they might come from. So I've covered a few of the main traits, and obviously these slides are going to be available for you to have a look in more depth if you want to. So there's sort of influential events. Interestingly, this, even though it's a 2020 paper, it doesn't have Generation Z on it. The education bit, though, is interestingly, for the pre-boomers, education was seen as a dream, so it was something you aspired to and you didn't always necessarily have. For my group, it was sort of seen as, well, you need to be educated so that you can be part of society. Generation X, they see it as a way to get to where they want to be. And then millennials and Gen Z see it as an overwhelming expense, and actually, is it really worth it? So very different views on what that looks like, but that does depend on the actual situations that you're doing your undergraduate education and postgraduate education in. For sort of a bit more of sort of how people work, I've mentioned about the boomers. If you think about it, Generation X, which are the ones from 65 to 80, they're in the management roles. Millennials are heading into those management roles and are quite keen to do that. And then the Generation Z are the people who are now coming through and looking at situations and thinking, I'm not sure whether I really want all the hassle to do with being a manager. Ultimately, I might take a slightly different career pattern. So how does that help us? Well, it helps us because certainly from an undergraduate point of view, we're dealing with Generation Z students. And interestingly, the attention span of somebody who is in Generation Z is tiny. It's about 8 seconds, which I was horrified when I heard from the person who was speaking in the university. It was only slightly bigger. It's only slightly bigger for millennials of 12 seconds. Perhaps more interestingly, if the Gen Zs are focused on one activity and you lose their attention, it might take about 20 minutes to get them back on track, which might be the rest of a teaching session. So when you're sort of thinking about your teaching session and what those faces look like around the room, maybe this is something to think about. It's not necessarily their fault, it's just that the way that they consume education. So I suppose for us as educators, we often see people as not engaging, but often they might be, but just not in a traditional way that we are used to. So they're very used to, and I'm sure if you have Generation Z people in your household, you will be very used to them using lots of different modalities all at the same time, and you sort of say, how can you possibly be learning or concentrating? And they just are. Even though for us, we certainly for myself, I would need to use one modality at a time because I couldn't cope with all of the other things. So just something to think about when you are teaching. For the millennials who might be our postgraduate group, then they are previously used to organised teaching. That's what it looked like. But the general thought is they might have reduced resilience and sometimes struggle with assignments and examinations if they don't do as well as they would hope. They often like to learn collaboratively, and so quite like simulation sessions because that's much more about collaborative learning. They will often quite like to revise together. If they can. That doesn't mean everybody, and I suppose what we've got to do is think about this is only one element of learning. This is not necessarily taking into account learning style or actually the jurisdictions that are placed on our learners because of the systems that they're within. This is just one way of looking at the learning process. So for our Generation Z, which as I say is our current undergraduates, there are many other things that are their traits which may be important to think about. They're generally felt to be compassionate, but they can be fiercely critical of each other. So sometimes if you're doing group work, you have to factor that in. They often are they have less preference for working with each other. They might actually be a group of people who would prefer to learn on their own. Certainly, and I'll come to my experience of our current students, but you often hear them talking about, I go to the library because it's quieter and I know people aren't going to interrupt me. They often are anxious about new situations. They're often very fearful of missing out. Anecdotally from the team at the university, they are very fearful in Freshers Week, whereas when I attended university, it was seen as right, we're all in this together. We all need to get on together. We'll make friends for life. They're much more fearful about meeting new situations. They want to know what the new situations are going to be like, even before they even think about going into a new situation, which is a very different process. They're often very critical of teaching methods if they don't feel that they're meeting their needs. And certainly I have noticed a change in our evaluation via the university when we're teaching medical students. They are much harsher in their criticism, or they give criticism, whereas in perhaps the past people just didn't bother. They are very keen to have a relationship with their facilitators and educators. They feel, and there's lots of articles, admittedly articles that are relatively old, that suggest that they fare better if they feel that their tutors, their teachers, their educational supervisors are invested in them. So trying to find out a little bit about them makes their motivation levels go up. They feel that we show that we're invested in their learning and who they are. There is an issue about over mothering or fathering in that situation. It'd be interesting to see what people think about that, whether we're actually making that too easy for people. They want us to show responsiveness and engagement, so effectively they want to see that we are involved in teaching rather than just turning up and doing a session and then walking away as if we didn't care about it. And there are quite a few admittedly American articles where they interview Generation Z students, and a lot of them are about I work better when I feel somebody's easy to talk to. I feel that if people make me feel not like an idiot, I'm much more likely to ask questions. You could say that's across the board, but it's very much for Generation Z students. I suppose what we need to do, and what they really want us to do, is check in with them along the way about how they're doing with the teaching. Do they understand what we're teaching? Do we need to go back over things? Which is slightly easier in a small group teaching session, but certainly not very easy in large lectures. I'll come on to my sort of experience of large lecture teaching for the university. Another quote, difficult material has to be relatable. If we can use examples and anecdotes, that sticks in your brain, so it makes it much more understandable. So it goes back to the stories, perhaps that Claire was talking about. And some of the evidence shows that if they feel that you're engaged with them, they are much more likely to want to please you. So they are much more likely to be involved in those teaching processes. Whether that's the right way round, I'm not really sure. I would hope that they would be involved in education for the sake of doing a good job ultimately, but actually maybe we have to take our wins from somewhere. So what might help? So because I was doing this talk, I've consequently been asking our fourth year medical students, and we've currently got final year medical students as well at the hospice, and asking them what they like about the teaching or not like about teaching that happens in the university. So what they really like is a careful explanation about why we're asking them to do what they're doing. So why do they need to do this particular assignment? And what they really want to know is it going to be beneficial for me when I work in the future? How is that going to work for me? Now, that is actually quite difficult if it is part of the curriculum and the course. But what you've got to try and do is engage them in why it could be helpful for them. So I think this teaching help session on how death certification works in the medical examiner role is going to be really important to you, because this is a role that you're going to have to do as a foundation doctor. And I am going to walk you through this and help you understand how you're going to have to partake in that role. They like us to use cases and sort of lived examples if we possibly can, which goes back to the storytelling bit. And they need positive encouragement that, you know, you need to do this because this is going to make you the best nurse, the best doctor that you can be. So how do they learn? Generally by doing, so working through things, by seeing, so that is reading course materials. What they absolutely hate to a person is they don't like lectures. And then they don't, and they, when I was talking to them yesterday, because we had a new group that started yesterday, they see small group and tutorial work as very different to a lecture. Or so they said to me explicitly, we could be a group of 6, but you could still be lecturing us, and we don't like that. We don't like not being involved in the process. So that's the key. So as I said, they want to have relevant for their role. We need to be explicit to this. So since hearing the person speak in the university, I've actually changed the way I set up clinical sessions. So I explicitly talk to the students about what I'm hoping they will get out of a ward round before I even start. This is why it's important. This is what we're hoping you are going to experience. We will then look at the learning along the way with that. So I've actually changed how I orientate them. They like supervised case histories and the practical situation of managing situations if possible. They want to see patients but they want to know that that's been set up so it's a learning environment, not just they're on a ward round and nobody really cares that they're on a ward round. And very much universally, we hate lectures that aren't interactive. So that goes for, in Liverpool University, there's quite a lot of recorded lectures. They hate those as much as they hate sitting in a lecture theatre. Because they're not interactive, they feel that their attention span is very poor. They do talk about 20 minutes is their max, interestingly. And if it's any longer than that, then it's pointless. They just switch it off and they don't go back to it because they feel that they've done enough of that topic, which is actually quite hard when you're doing certain topics as a lecture. So for me, I do lots of different teaching. So next year, our medical student cohort is going to be between 360 and 370 in the fourth year. So I have just delivered a lecture on attitudes to death, dying and bereavement to the first year medical students. And there was about 360 in that lecture theatre for an hour-long lecture. I am given the title, I am told they will turn up for the lecture, and I have to deliver it with a curriculum, knowing what the curriculum outcomes should be. How I make that interactive when we're dealing with a really difficult subject is really hard. And if anybody's got any views, I am more than willing to listen to it. They are compulsory for them, so they do have to attend. So, but that's the main reason why people are sitting in that lecture theatre. I'm very well aware of that. That is not what they want to be doing. They also see themselves as consumers because they're paying hefty amounts of money for undergraduate courses, as are people doing postgraduate courses. And so they are very much into the well, I didn't think that your teaching was up to scratch, so I'm going to tell you that. And that's where that critical appraisal comes in, where previous generations perhaps were less likely to do that. So in summary, what can we do to make our teaching, the simple things to make our teaching more effective possibly? So we need to support those groups of students as they are, along with all the other elements of how we manage teaching and facilitation. Try and set your teaching up with an ethos that it's going to be helpful, and orientate it towards how you do that, and sort of demonstrate that within your teaching session. Try and keep them shorter if you possibly can. For us in palliative care, we do have to think about that safety in learning and how we support people through that. I think we are very good at that in palliative care, much more so than in other maybe specialisms. One of the other issues that has come out quite significantly for Generation Z is they don't want us to pretend we know stuff when we don't. They want us to be honest and open and truthful if we don't actually know the answer to a question. And they see that vulnerability as quite a positive trait, rather than seeing it as, oh, well, you're no good as a teacher because you don't know what you're talking about. They don't see it like that at all. And what they also want us to do is create a sort of an environment where they feel supported and we respect them as learners in their entirety. So quite a lot of references there. I say some of them are really old. There are some newer things coming out. Paul Redmond, who's the person who gave us the talk in the university, was a director of student experience and enhancement at Liverpool. He's done quite a lot of work, but in fact, all of his work seems to be book related rather than actual article related. So, I mean, obviously, I'm sure you can go and buy his book, but maybe you won't want to do that. So I'll stop sharing.